Hello, everyone, and welcome to today's webcast, Is Your Data Working for You? With a focus on health data and featuring active health management. I'm Barbara Lombardo. I'm Program Director and Research Fellow at the Conference Board, and I'm delighted to serve as your moderator for today. What we're going to be talking about, and I want to preface this with just a construct around data. I think so many times when we talk about data, it's about how we extract meaning from it, how we make it useful to us. And there's a construct that I was taught a long time ago that I find very, very relevant to these conversations, and I want to share it with you today. And I think it really does serve as a framework for our discussion. And it's simple, 4 parts. Our fundamental goal with data is to translate that data into insight, and then take that insight, translate it into action, and not just any action, not just acting for the sake of acting, but specific actions that will yield our intended results. So data into insight, insight into action, action yielding our intended results. And you'll hear that in our conversation today. We're also going to address, and rather than an agenda, I think of these as kind of the themes that we'll touch on today. And first, and remembering we're talking about healthcare data, how to see people like the whole person, not just their condition. It's very hard to not just hone in on diabetes or whatever that condition is, but to step back and look at the whole person, the context in which they live, their whole environment. Second, we're going to be talking about removing barriers to health. Those aren't just access. It can include information, it can include insight, it can include motivation. There's a lot of barriers to health, and we'll talk about removing those. Third, and here again is where our mantra of data to insight, insight to action, action to results plays. We're going to be talking about delivering measurable results, ones that you can actually track and demonstrate impact. So, kind of summarizing, we're going to talk about how to use data to yield insights that can lead to better health outcomes, more relevant and inclusive support, and lower healthcare costs. So before introducing our speakers, I just have 2 housekeeping reminders for you. I know you've seen these, and they were listed in the slide that was up while we were playing our intro video, but these are just 2 things to remind you of that are especially important housekeeping reminders. First, for those of you interested in earning CPE credit for attending and participating in this webcast, you click the link in the CEU request widget and sign up for that credit. And then there's 3 other things you have to do too, but they're easy. First, stay online for the whole webcast. We want to know you're here. And the way that we confirm that you're here is about 3 times during the webcast, there's going to be this pop-up box that comes up, and it asks you to click OK. I think there's like a check mark, and you click OK. And that's a way for you to confirm that you indeed are with us throughout the duration of the webcast. So make sure to do that. And then the only other reminder regarding credits is you have to be participating in the live version, not the recorded version that is available on demand later, in order to receive those credits. So one last reminder or housekeeping reminder, and then I will introduce our speakers. Our speakers love interacting with you, and they don't want to just talk to you. They want to be responsive to the things you want to hear about. They really want to hear your questions. So I want to encourage you, and do this when you think of that question, when that person is talking, type into that Q&A, that Ask Question Q&A box widget, click on that, type your question in. One of the things I will be doing throughout the hour is monitoring those questions, and then I will be posing them to our speakers at breaks throughout the whole webcast, so we can make sure to address the questions that you have when you're thinking about them, or very soon thereafter. We also hope to save time for further questions at the tail end of the hour, so we can do that as well. But again, when you have that question, so you don't forget it, type it into that Q&A box and we will get to it. So now I'm really happy to introduce our speakers, both from Active Health Management. First, Bonnie Veer. She is the Senior Medical Director at Active Health Management. You see her photo here. I am sorry to say that she was not able to join us via camera today, but you will hear her voice and you can see her here, her still on our slide here. We also have Scott Sobocinski, who is the Executive Director of Clinical Analytics, also at Active Health Management, and you get to see him live on camera. So he's here with us both on camera and by voice today. So with that, I'm going to turn to Scott to get us started.
That sounds great. Thank you so much, Barbara. And thank you everybody for being here with us today for our webinar entitled, Is Your Data Working for You? To kick things off, we wanted to give you a sense of who Active Health is as a company. So we are a part of the CVS Health family of companies, and we're an innovator in applying science-based coaching and technology solutions to address real-world problems in healthcare. In terms of thinking about our customers, we serve employers, health plans, and third-party administrators, and also providers with clinical solutions to deliver personalized digital and live experiences in order to improve health outcomes and drive measurable cost savings. So we have over 20 years of experience in the care management and clinical analytics space. And our technology solutions, I know the slide says serve over 20 million members, but right now we actually are serving over 25 million members with our technology solution. And as a company, we're made up of over 800 clinicians, digital and IT staff, as well as supporting staff in the areas of sales, marketing, and account management. And finally, we're excited to show that we have highly satisfied members and customers. The member satisfaction rate with our well-being solution is currently at 99%, and we deliver a 3.6 to 1 return on investment to our customers with that same well-being solution. And also, our customers tend to remain customers for quite some time. We have an average contract length of 6 years currently. Would you go on to the next slide, please? Thank you. So at Active Health, we believe in whole person health backed by intelligent technology. We were founded on the notion that we could use technology to amass a complete picture of members' clinical profiles. We could identify various opportunities to improve health and then put that information in the hands of treating providers and members so that everyone had access to the same information. So since our founding 20 years ago, our capacity to refine and deploy sophisticated analytics has only grown. We've become more predictive in our targeting of members who need clinical interventions. And we've also developed a single metric called the Active Health Index to assess health across a population. And we continue to react timely to the latest evidence-based standards of medical care. So core to our mission are 3 key pillars that we build all of our clinical solutions around. First, our solutions see the whole person, not just a narrow view of specific conditions and medical events. Next, we strive to address social determinants of health and issues of health equity in order to remove barriers to health improvement. And finally, through our clinical solutions, we seek to create generational health for our members and for their families. Would you go to the next slide, please? So the first pillar that I want to take a quick look at today, a closer look at today rather, is using data to see people, not conditions. Could you go to the next slide, please? So I'd like you to think a little bit about how you describe yourself to someone in a couple sentences. So for me specifically, I might say that I'm a 40-something guy. I work with data and analytics. I live in Southern California, so I really love hiking. One of my favorite foods is macaroni and cheese. and I'm probably going to sing along to the latest Lady Gaga song if it comes on the radio when we're in the car together. So if you knew me from work, you definitely know the first 2 things, a rough sense of my age and the fact that I work with data and analytics. However, if you knew me casually in my personal life, you'd probably know about, my enjoyment of hiking and my favorite food. However, I think you'd have to know me really well to know that last piece of information, and also to be subjected to having to hear me sing in the car when you're riding along with me. The point here being that we're all made up of slivers of information that we acquire about each other, depending on the context of our relationship. And the better you know someone, the more complete of a picture you're going to have of that person. And we really feel that it's the same when you think about members and when you think about all the different sources of data that you can have for your members. Could you move on to the next slide, please? So at Active Health, our clinical analytic platform is called the Care Engine, and we're able to bring together data from a wide variety of sources. And each source is a sliver of very important information about the member. This enables us to create a complete picture of that member. And we call that profile of a person the member health state. So in order to build the member health state, we're able to ingest and normalize medical claims data from any payer source, electronic health records, pharmacy data from any PBM, also lab data, wearable and medical device data, and health assessment data. And that's really just to name a few of the data sources we leverage in Care Engine. And we bring all of these things together to build a complete picture of a person that, again, we call the member health state. Could you move on to the next slide, please? So being able to bring in and normalize all the data is really just the first step in unlocking the potential of this information. We translate and analyze the data using peer-reviewed, evidence-based clinical analytics to find opportunities to improve care. The clinical team that I lead at Active Health has developed thousands of rules and models using the evidence-based medical literature to create the member health state out of data. And when we think about the member health state, it's made up of many components. So a couple of them are things like chronic and acute condition identification, the identification of lifestyle risks, also gaps in care, compliance with quality measures, and also identification of barriers based on members' social determinants of health data. As we build out the member health state, we'll be continually ingesting new data in the Care Engine. And that means that the member health state is continually updated. And that enables us to build a picture of the member's health profile over time. It's important to understand that the clinical analytic insights in the member health state serves as the foundation for all of Active Health's products. And we use it to do a couple large categories or broad categories of things. So first thing we do with the member health state is we use it to identify and risk stratify members for our care management programs. We also use it to flag modifiable health improvement opportunities for our coaches and for our care managers. Next, we use the member health state to communicate gaps in care to members and providers. And we do that leveraging a wide variety of communication channels. And finally, all of the clinical insights in our Care Engine are used to create a highly personalized experience for members in our digital platform that we call our member engagement platform. Can you please move on to the next slide? So at this point, we've really talked a lot about seeing people and not conditions, but we've done it in I've done it in a pretty academic sense. So I wanted to share two member stories with you to demonstrate the real world impact of how we use data and analytics. So recently, our care management team was working telephonically with a member in our condition coaching program who was struggling with worsening anemia, also a GI bleed and some pain issues. And the first thing his doctor did to try to address this was to discontinue his blood thinner and prescribe a different one with fewer side effects. But unfortunately, the member continued to have issue with anemia. So this member ended up being referred by one of our Active Health care management nurses to an Active Health pharmacist for a pharmacy review. And during the pharmacy review process, the members' claims data showed a prescription for 600 milligrams of ibuprofen. And strangely, there was no mention of this prescription in the notes from the doctor or from the active health nurse who was working with the member. So what our pharmacist did ultimately was get in touch with the doctor and let the doctor know about the ibuprofen. And the doctor actually immediately switched the prescription from ibuprofen over to Tylenol. And the member's condition improved within a couple of days. And he contacted us to let us know how much more energy he had since stopping the ibuprofen. Also, he reported having a better appetite and better skin color. So, in telling this story, and I'm a pharmacist, Bonnie's a physician, it may sound very obvious to the clinicians on the webinar today that the ibuprofen was the culprit. But in this case, the treating provider and our nurse didn't know about the ibuprofen. Our pharmacist, however, was able to spot it in the prescription data that we had in the care engine. And that's really, that single piece of data made all the difference in the world to this member, because it helped him through the experience that we was having with side effects from the medication. For our next member's story, his health assessment data indicated that he was a former smoker. And our evidence-based clinical analytic rules indicate that smokers and former smokers are at higher risk for something called an abdominal aortic aneurysm, or a AAA. So based on the fact that the member was a former smoker, and he told us this in his health assessment, this member triggered a care gap, and we issued an alert to his provider suggesting a screening for a AAA. So the provider scheduled the screening, and the member had it, and they found a large aneurysm. So fortunately, the member came through the surgery successfully, and he credits Active Health with saving his life. His surgeon actually wrote to us and said, "I can't believe you got a letter from your wellness plan telling you to get this checked out. Most of the time when we find a AAA, it's when the patient comes in dead as a result of one rupturing." So in this story, it's not more than just a single piece of data. It's us bringing together the data with the evidence-based clinical rules in comparison to guidelines that led to Active Health recommending this screening. So in thinking of our approach to seeing people and not conditions, when I think about working with members on a specific issue, leveraging a point solution, like some of the solutions that we see in the marketplace, like something that's maybe narrowly focused on high cholesterol or diabetes, would we have even been thinking about this member's history as a smoker and preventive screenings? Probably not. So this is why we think our whole person health approach and the breadth and depth of the clinical intelligence that we have in the care engine rules is something that is critically necessary to have in order to make solutions that ultimately make a huge difference in your members' lives. Can we move on to the next slide, please? So we talked about the real world impact that your data can have on individual members, but ultimately our clients want us to be able to measure and quantify the impact we're having on the health of their population. So we developed a measure called the Active Health Index because over and over again, we heard from our consultants and our clients, they were asking us, how can we measure health? How do we know it's improving over time with your clinical solution? So that's what we set out to determine when we developed the Active Health Index. So the Active Health Index is a single metric that helps to quantify health both at the member level and also at the plan sponsor's population level. So what we're doing, again, is we're running large volumes of data in the care engine through thousands of clinical rules. We're then distilling that into the member health state, which contains hundreds of clinical markers that we then organize into 8 dimensions of health. And some of these dimensions are considered to be established or non-modifiable. And that would include things like your age and your gender, and also the presence of medical and behavioral health conditions. While other dimensions are considered to be modifiable, and these would be things like adherence to evidence-based care, lifestyle and biometric risks, medication adherence, preventive care, and also at-risk conditions. And with the Active Health Index, what we're doing is we're measuring improvement in these modifiable dimensions because those can have a significant impact on a member's health over time. Could you please move on to the next slide? So I wanted to give you an example of how the Member Health Index works at the member level. So let's think about our member here, and her name is Marcia, and she's a middle-aged woman who has some substantial health challenges. So she's living with multiple chronic conditions, including diabetes, heart failure, high cholesterol, high blood pressure, and depression. And unfortunately, because of all these challenges, she's not necessarily the best at taking the medication as prescribed for these chronic conditions. So she's non-adherent to several of her drugs. She also triggered 4 gapping care alerts, which she has not yet addressed with her provider. And she has lifestyle risks, such as being obese and also not getting enough sleep. And finally, from a preventive health perspective, she's past due for her breast cancer screening. So on the right-hand side of the slide, you can see a graphical representation of what Marcia's health index looks like across the 8 dimensions. So first, the health index is scored from 0 to 100. And there is an overall score, which on the slide here is shown as the AHI. And the AHI includes both the modifiable and the non-modifiable dimensions of the health index. But we also have a score called the MHI, which is the modifiable health index score. And this accounts only for those modifiable dimensions. And Marcia's modifiable score is a 54 based on all the challenges we identified in her clinical scenario. And that means she can improve her score by 46 points, right? Because 46 plus 54 adds up to the 100 points, which is the best possible score. So as we follow Marcia forward in time, our clinical solutions will help to address Marcia's challenges. And we can reassess Marcia's health index at various points in time while she is engaged with our clinical solutions to measure improvements in her health state. And finally, from a product perspective, thinking about how we use the MHI, we use this score to risk stratify members for our care management programs, as well as in our client reporting to show how we're able to move the dial on the health of a customer's population as they engage with our clinical solutions over time. Could you move on to the next slide, please? So our focus up until now has largely been on the data and the analytics. And we talked about how you can leverage multiple sources of data to create a complete picture of a member and then apply that data to the evidence-based clinical analytic rules and models to identify health improvement opportunities. But that is not everything that you need to make your data work for you. When we engage people to improve their health, the kind of changes they need to make vary. And their reasons for making changes will vary. And on the flip side, the reasons why they're not making changes will vary as well. So you need to be ready to identify anything that pops up as a barrier to improvement and find a way to remove it. And at this point in the presentation, my colleague, Dr. Bonnie Veer, is going to be taking over to discuss how our clinical solutions focus on identifying and removing barriers. But actually, before I hand it over to Dr. Veer, I wanted to pause for a moment and see if there were any questions that we wanted to address now based on the data and the analytics and how we apply that to evidence-based standards of care.
Oh, Scott, I'm glad you did that because there are several questions that are very relevant to what you just shared with us, and answering them, as soon as possible after they're posed is really helpful because your comments are top of mind for us now. So here's 2. First one is you showed us a slide that had many sources of data that you tap, to create your insight. How do you identify new sources of data?
A lot of the identification of new sources of data is driven by new medical technology. So for example, when we first started in this business 20 years ago, there was no such thing as an Apple Watch, or a glucometer that you could connect via Bluetooth, to your computer. So that is one of the major ways that we identify new data sources is keeping up with the evolution of new medical technology.
That's helpful, thanks. And I imagine as more technology emerges, that'll give us even more potential sources of data to tap.
Absolutely. Absolutely, Barbara.
Yeah. So another question relevant to what you just shared with us, you use the term care gaps or gaps in care. And I think you referred to several specific ones when you were showing us, was it Marcia? The profile?
Yes, Marcia.
So when we were talking about Marcia, you talked about gaps, care gaps. Can you say more about the kinds of care gaps that exist and how do you identify them?
Sure, absolutely. So in Care Engine, we have over 1,000 evidence-based gaps in care. I know that there are a lot of solutions in the marketplace that they identify who needs a flu shot, the who with diabetes needs an eye exam, sort of a handful of things that are heavily focused on things like HEDIS measures or STAR measures. We certainly have all of that, but then plus. So the 1,000 evidence-based gaps in care that we have span over 200 different conditions. And we go very, very deep into the clinical guidelines. So some of the categories of care gaps that we have would be recommending, for example, when medical therapy needs to be added or intensified. So for example, we may identify that someone has diabetes, that their hemoglobin A1C isn't at goal, and that nobody has done anything to their diabetic regimen recently. So for example, nobody changed the dose of a drug like metformin, and then we'll send a nudge to the member and the provider to try to get their diabetes therapy changed to address their hemoglobin A1C, which is not at goal. We also have a suite of alerts that look for when people are taking drugs where there's a contraindication. We look at drug-to-drug interaction. We look at screenings that are necessary in order to monitor drug therapy. So honestly, the Care Engine has a library of care gaps that we feel from its breadth and depth clinically is really unmatched from a product perspective.
Thanks. And we'll do one more question on the data theme that you addressed, and then we'll turn to Bonnie. You used the term social determinants of health data. I think it was in the chart where you showed us all these different sources of data, and one was social determinants of health. Can you talk more about that? What is that, and how do you use it?
Yeah, sure, absolutely. There's two ways that we're able to get social determinants of health data. There actually are ICD-10 codes that providers can submit to identify when one of their patients has a social barrier related to social determinants of health. And we ingest those into Care Engine, and then we use that data, for example, to flag a social determinants of health, or it's sometimes abbreviated, Barbara, SDOH. So to flag an SDOH barrier for one of our care managers. So when they're working with a member telephonically, they, for example, may know that the member may have challenges with health literacy, and then so if the nurse knows the member has a health literacy challenge, they're going to approach that interaction with the member a little bit differently. Also, as an enterprise at CVS Health, we've created some enterprise level data that's based on things like, it's called census tract and census block level data. So for example, looking at a member's zip code, you can infer a lot about whether a member has barriers related to social determinants of health. And we also ingest all of that data into into Care Engine as well. And we use it, again, in how we're approaching an individual member in our interactions with them, whether it's through care management or through how we message gaps in care to them.
Thank you. That's really helpful. And you used the example of health literacy as one example of a social determinant of health, or SDOH. Can you just give us one or two other examples to make sure we kind of comprehend what that term really is about?
Yeah, sure, absolutely. Another thing would be challenges with transportation, housing insecurity, folks who live in a food desert. We may flag that somebody living with diabetes and a high risk of heart disease needs to be on a statin. But if they have issues with transportation, they can't get to the doctor to get a prescription. They can't get to the pharmacy to get it filled. You need to be able to address those things as well. So it's not just identifying gaps in care, it's also helping the member to close those gaps.
Perfect place to end, because that's about removing barriers, right? Which is what Bonnie is going to talk with us about now. And for those of you who weren't with us when we did our introductions, Bonnie is not able to join us on camera, but you will hear her voice as she does the next part of the webcast.
Thank you, Barbara. Can everyone hear me okay?
Yes.
Great. And thank you to everyone for attending our webinar again today. My apologies for not being able to join you via camera, but I hope that you'll still find the next several slides and our discussion here engaging. So Dr. Sosinski already talked to you about the ways that we at Active Health identify health opportunities for people that would benefit from some intervention or action. And to add to that, and some of what he's already spoken about just now, we need to understand what barriers exist for an individual, whether they be physical, social, psychological, environmental, or economical, and if they are impeding those people from achieving their optimal health. Unfortunately, good health remains a privilege and not a right yet, but at Active Health, we're trying to make it more of a reality for more people. Next slide, please. So I don't have to tell everyone here, we've all just come through 2 incredibly difficult and unprecedented years when health and healthcare was brought to the forefront of the entire world's collective mind. And in the U.S., the pandemic shed a glaring light and exacerbated an already existing physician and provider shortage crisis in the healthcare industry. 20% of healthcare providers left the healthcare field during the pandemic, and 14 million Americans already lived in a medically underserved area. With appointment shortages and wait times for patients continuing to grow, it makes it all the more important that when you do get an appointment with your provider, you make every minute count. And that may be limited to, on average, 15 to 20 minutes. So that's where we can come in and intervene. We can help people understand their existing conditions, risk factors for emerging conditions, and how to mitigate those effects. We can offer them the education they need to make informed decisions about and deliver it to them in a way that makes them the most comfortable. Whether that be a discussion with their care manager, reading materials sent to them in the mail, or digital links to content that they need, and help them prepare for visits with their providers by arming them with questions that will help them to better voice their concerns and learn about their health and treatment options. And then where healthcare technology can help us acquire new data, we can encourage adoption and teach members to use those devices correctly. And then we can even give treating providers access to that data within their electronic health records. So it's really all about personalization and tailoring how we use all of the rich data that we receive, and I'll talk about that some more on the next slide. Next slide, please. So machine learning is all about growth and evolution. It's adaptation rooted in data. But equally as important is understanding what does the member need? What are they interested in, and what are they interested in interacting with? What would be an effective resource or next step for them to help them continue to build their knowledge, their self-sufficiency, and confidence? Intelligent technology is only effective if it ingests data organically behind the scenes based on what the member is actually doing and not what we think they might be doing, and if people are actually using it. So at Active Health, we're always thinking about new sources for data and new ways to integrate it, as Dr. Sobocinski already touched on. Wearables and biometric devices are a great example. If you think about the early iterations of these, they were basically pedometers that, were kind of low tech, just using body movements to count steps. But we've come a long way since then, all the way now to using wireless scales to help alert us when a member with congestive heart failure is retaining a dangerous amount of fluid, to getting alerts about life-threatening changes to blood pressure or heart rhythms and blood sugars. And these alerts give clinicians the ability to make a close to real-time impact on the lives of our members. So as the data comes in, our clinicians get an alert and they can react by notifying the member and even the treating provider if needed. All the while, our care engine is running continuously in the background and offering up new and prioritized health actions and interventions as the data comes in. So I'm going to stop there for just a minute, Barbara, and ask if there are any questions before I move on to the next slide.
Thanks, Bonnie. No questions yet, so you can keep going.
Great. Next slide, please. So we've been doing this for nearly 25 years, and we've remained committed to the idea that the right piece of data can change the course of a person's health. Dr. Sobocinski already gave you some examples of that. We'll also point out that a recommendation delivered at the wrong time to the wrong person or in the wrong way isn't just ineffective, it could be harmful. That's why personalization of harness data into actionable items and offering specific resources to those people who really need them when they need them is so critical. It really isn't simply about grouping people together, like men over 50, people with diabetes, and sending them generic messages that may not apply to them. I'm going to pause for 1 second. I switch over to my phone because my headphone is dying. Can you hear me okay still?
Yes.
Yes. Great. So for example, an example of a generic type of message or generic type of information. An ACE inhibitor is a class of medication that's important for blood pressure control, and it's protective. It's renally protective for people with diabetes. But sending a message to everyone with diabetes about the importance of taking this class of medication is simply too broad of a sweep. ACE inhibitors have clear contraindications, being pregnant for as one of them. You certainly cannot start a pregnant person on an ACE inhibitor. It could be harmful to them and their babies, as well as people who might have an allergy to this medication. So sending a message encouraging the use of this class of medication to every member with diabetes could be harmful to specific people, even if it's beneficial in general to the majority. So by ingesting rich, clinically valid data from a variety of sources like claims and labs, wearables, electronic health records, and even directly from patients themselves, and harnessing the power of machine learning and aligning all of that with literally thousands of proprietary clinical rules and algorithms, that can get us to a level of personalization at the individual level. It also helps maintain our clinical excellence and credibility with not only our clients, but our members who trust us with their health, and even within the medical community. And another way that we can individualize and personalize our clinical content to an individual is in how it's delivered. You know, not everyone wants an email, not everyone wants a text, and not everyone wants to use an app. And if you're like me, you might not want someone calling your phone, and you might screen any unfamiliar number. You know, so if I'm repeatedly called by anyone I don't know, I'm probably going to get annoyed and send it directly to voicemail, and I might not check that voicemail. And then I might miss some valuable information that I needed to know, like a medication interaction between two prescriptions that I'm taking. But if I receive that same message as a text, or at least a text notifying me that I have an important message waiting in my health portal or app, I'll probably go check that. On the opposite end of the spectrum, someone like my father, who would never even know how to check a text message or use an app, and he thinks every phone call is important, so he's going to definitely pick up the phone. So knowing how our members want to be notified, educated, outreach to, et cetera, is just as important as the health information itself, because what good is it if we have all this important information, but a person doesn't want to hear it in the way that we're delivering it? Next slide, please. So when your health needs are simple, you can usually handle them with your PCP. One doctor who knows your medical conditions, your medical history, your pharmacy needs, etc. But when your needs become more complex, you might start seeing a specialist or even more than one. And often they're not talking to each other, and neither are their healthcare systems. So they rely on you, the patient, to tell them if your prescriptions have changed and if your health has changed. One of the ways that we've tried to navigate that gap is by integrating with a major platform like Epic, which allows us much better interoperability among providers and clinicians on a person's healthcare team. So 75 to 80% of patient data is available through this collaboration. So integrated data from multiple sources in an EHR like Epic flows into our care engine, which processes them through the thousands of evidence-based clinical rules, and is always also scanning the entire membership to deliver up the best evidence-based clinical recommendations to their treating providers, and whether or not that person could benefit from one of our clinical programs. And this all helps to create a richer, more accurate profile of all the risk factors and potential areas that can be impacted by our clinical program. It also helps us to understand the member's treatment plan and helps us answer questions that the member might have regarding their treatment plan set forth by their doctor. We can spot some gaps in care that they might need to address, and it takes some pressure off of the member to understand their treatment plan and share it with us accurately. We can see directly from the provider's notes what's happening with their health, rather than expecting the patient or the member to remember all of that information accurately. Next slide, please. So by operating within Epic, we now have direct connectivity with our members' treating providers. This allows us to deliver messages directly to the member's electronic health record for use by their physician. We can also send our notes and care plans to them, and the physician can see it. And they can also see any barriers that we've identified that might prevent the member from reaching their goals or the goals that their MD has set for them. And that data is bidirectional. So we can also receive information from the MD visit notes, as well as data collected from the EHR, such as labs and biometric results and vitals, blood pressure, historically being a difficult one to capture, as well as changes in prescription information and social determinants of health. So our clinicians and coaches can read the notes from the treating providers, provide real-time feedback to the member rather than having to outreach to the provider, wait for a call back, and then calling the member back with that information. This is just much more efficient. And improving that efficiency helps improve self-sufficiency for the member and gives them the confidence they need to make more informed healthcare decisions. The members have a richer, more accurate view of their own condition, as do the healthcare teams and the active health clinicians. Next slide, please. So as Scott already discussed, the Active Health Index is one of the ways that we can help our clients by using a single metric to determine the health of their population all the way to the member level. But we also consistently evaluate the performance of our solutions against established goals. And we have, over the years, published several, in addition to giving our clients, their annual results and ROIs and data analyses. We've also published several studies and papers over the years that we'll touch on over the next few slides. Next slide, please. So one of the recent studies that we put out there was a randomized control trial of over 1 million Medicare members. The results of this study showed a statistically significant difference between the study group, which received our Care Engine-driven alerts, and the control group across medical and pharmacy cost savings, reduced inpatient costs, and reduced cardiac procedure costs. And if anyone is interested in learning more details about this study or some of the other ones we published, we can certainly provide a more in-depth review at another time. Next slide, please. Oops, 1 second. I lost my screen for a second. So our coaches work closely with members using motivational interviewing techniques to meet them where they are. They're able to develop trust and rapport with people and try to understand what their why is. Do they want to improve control of their diabetes because they want to be around for their grandchildren? Do they want to quit smoking because they want to be around long enough to attend their children's weddings? Just, no matter what we think is important, if a person feels like we are treating them as a condition instead of a whole person, we might never get our foot in the door with them to make a difference. So some examples of our successes using these techniques are highlighted here. These are results from 2021, showing that members engaged with our lifestyle and condition coaching program showed significant improvements in their cholesterol, their blood pressure. They had fewer sick days lost from work, and several even managed to quit smoking. Next slide, please. By working with our coaches, our members are getting their HbA1c checked, they're controlling their blood pressures, they're using their medications appropriately, including their asthma controller meds and their statins. This translates to a healthier population overall, reduced emergency room visits, and fewer hospitalizations, leading to lower healthcare costs. So what we're seeing here is that members engaged in our programs are truly engaged and invested in their own health. Next slide, please. And over the last couple of years, we worked on a home heart health pilot program. In this pilot, members received a weight scale along with an iPad, a dedicated coach, and daily check-ins. These were folks who had congestive heart failure. By establishing an enriched data flow directly from members and their devices, educating them about their conditions, medication adherence, and the signs and symptoms that might mean their condition was worsening, we empowered them to avoid several adverse events. This pilot ended with a reduction in inpatient admissions, outpatient visits, as well as emergency room visits, not only giving these members the ability to stay healthier and out of the hospital, but also it reduced the strain on an already stretched out healthcare system, as well as already stretched out providers. So, just some final thoughts, and to wrap up, we may only be as good as the data we receive, but it's really up to us to leverage that data in a way that is meaningful, useful, and practical, connecting the dots between data sources like electronic health records, admission, discharge data, connected devices, traditional claims, labs. All of that gives us insights in near to real time that allow us and providers to pivot as necessary for our members' pressing healthcare concerns. But how and with whom we share this data is just as important to get us to the other side of just insights and analysis and offer up instead some real support to people to improve health outcomes and lower healthcare costs. So with that, I just want to thank you all again for taking the time to attend today and participate in our webinar. And I'm going to pass it back over to the moderator for any additional questions.
Thank you, Bonnie. And we do have a couple more questions I'm hoping we can address before we do our wrap up. Thank you both for all this insight that you have shared with us. It's really helpful. So here's a question that I think inevitably arises whenever we talk about personal data. It always raises concerns about privacy. So our audience member asked, how do you address concerns about privacy? And what are you doing with all that data that you're collecting? I don't know, either of you, whichever of you is the best person to answer.
Sure, I can start with that one. What I would say about this is, at Active Health, we are fierce defenders of privacy. We certainly are not in the business of sharing patient or member data unnecessarily. We try to de-identify as much as possible. We don't communicate with people's providers without their explicit permission. There are people that our coaches and nurses have spoken to who have pressing healthcare needs, but they've explicitly said, no, you can't talk to my doctor about X, Y, and Z. I talked to a different doctor about that, and I don't want my one doctor to know about this. So we have to be very strategic in how we gain their trust, and we have to often figure out ways to not break that trust and not share data that they don't want shared, even if we think that it would be to their benefit. So that's the first piece of it. We are extremely protective of our members' data. And the other part of it, I would say, is just I think everybody knows now that your data is out there, whether you want it to be or not. There's probably more about your personal life if you use any social media out there than there is about your medical background and your medical history. So I would just, tell people to understand that medical history and knowledge about you isn't the only thing that's out there, and we are doing what we can, as are most health insurance companies and physicians. We're doing what we can to protect that information as closely as possible. so that your privacy isn't breached.
Thanks, Bonnie. Scott, anything to add on the topic of privacy?
No, I mean, it's a great question because it's always a concern. And, anecdotally, sometimes when I tell friends and family what it is that we do here, they think, oh, that's a little creepy, but I think that Bonnie did a great job of explaining, the level of seriousness with which we take protecting people's personal health information.
Thanks. So we have time. I'm going to bring just one last question, and then please stay with us because I have some wrap-up comments that I really want to make sure that you all hear. So last question, big topic. Maybe just give us your, summary kind of answer. You talked about, I think, when you talked about just the healthcare environment, obviously we are 2.5 years, is it? It feels like forever, into a pandemic. And you talked about the impact that had on healthcare providers and the healthcare system, really, really stressing it. So in addition to that, though, what effects has COVID-19 and the pandemic had on your program? And maybe even, how have you changed your program or what you do or how you do it as a result of the pandemic? Who wants to go first?
Yeah, I can start, and Scott, if you want to chime in here, that's a great question. As I mentioned, we're as good as the data we receive, and there was a solid chunk of time there when people couldn't get in to see their doctors, and things like virtual visits hadn't taken off as much as they are, as much as they have now. So yeah, definitely, we feel an impact whenever the data drops and there's less to ingest. We don't have, it's just simply not as rich. That being said, our healthcare coaches and nurses never stopped working. Neither did the care engine. Neither did Scott and I, and we made efforts to enhance our outreach, engage more telephonically, digitally, one-on-one, in groups, et cetera, with our members to keep that flow and lines of communication, open, and if our data was going to suffer in terms of what was available from claims and labs because people couldn't get into a doctor's appointment or into their lab, then we were going to take, the data that people gave to us, whether it was in our app or whether it was while they were speaking to their nurse over the phone, providing us their healthcare history, and using as much as we could to paint a complete picture. We were also very careful not to send false messages, that because of a lack of data, we didn't want to bombard people saying, hey, you haven't, had X, Y, and Z done, but we don't have the claims because you haven't been able to get in. We certainly didn't want to punish people for that. So we had some workarounds and made some valiant efforts to really try to capture as much data as we could and still maintain our relationships with our members during this entire pandemic.
Thank you, Bonnie. And in the interest of time, I think we need to wrap there. I just have a couple of comments to leave you with. First, thank you so much to both Bonnie and Scott for all that you have shared with us today. And I know that there are materials available. If you go to, let me go to your site. Is it activehealthmanagement.com? Is that your site if people want to find more? And then just 3 comments very quickly about the conference board. We've got so many resources available to you, and just 3 that I want to highlight. You know that we create hubs for you to address around very urgent and timely issues. We had a hub around COVID-19, one around the geopolitical hub, and now we have navigating the economic storm about guiding you through a global recession. So we encourage you to take advantage of that hub. Second, you probably have heard us talk about My TCB, where you can sign in and have curated and customized content pulled from the Conference Board website. And finally, I want to encourage you to take advantage of our CEO Perspectives podcast series, where our CEO, Steve Odland, interviews executives. Recent topics have been about Canada, about global semiconductors, board activism, so many other topics. So please take a look at those, and you can access them through any podcast channel. So once again, Scott and Bonnie, thanks so much, and thanks to all of you who joined us today.
Thank you, Barbara.
Thank you, Barbara. Thank you, everyone.